I'm actually live. Can you please see if you can see me?
Oh, did you use the...
Just go online, see if it's.
No, I am online. Yeah, I see you.
Oh, I'm live.
Yeah.
How do I look like?
Well, I only see your screen.
Oh, you don't see me?
No.
Oh, okay, that's fine. That's fine. Because actually,
Oh, yeah, 'cause I want to.
Oh, no, it's all recording, right? So, okay, let me see. I can as well put my face as well as needed. Let me see here. Let's see here. I can put a Zoom thing, but then who's going to join in? Or we can say somebody can. Yeah, let me start a Zoom.
You want Dr. Coach to join?
No. Maybe Neil can. You want to text Neil if you want to moderate? Let me start a Zoom thing, and then we can as well save it on Zoom. Then we have it there too. Zoom. Oh, installing updates really right now. Yeah. So,
Okay, I texted Neil.
okay. So you can even, for example, even send a copy of this thing to Neil or whoever else won't be the moderator. So we have a moderator as well. Okay. Let's see. I might have even Neil's
Now I see
email.
you.
Now you see me?
Yep.
Really?
I see you, but...
You see me or you see the sacroiliac joint fusion thing?
Well, now I see the sacroiliac joint fusion.
Good, good. Okay. Yeah, I have Neil's. I send it to Neil and I can send it even to you and Misha. So you guys can distribute it if anybody else wanna join. Zoom.
Okay. I'll post it on your LinkedIn.
Yeah, if somebody wants to come and join. So it's still online, right? So I'm just going to keep it going, and you can when you put it on, you can cut the initial piece, all this conversation, please. Okay?
Yeah.
Okay. Now I can put myself in that corner like this. Is that good?
Let me go back. I don't see you.
What? You should be able to see me.
Now I see you.
Okay. I think it has 5-second delay or something like that.
Yeah, I think you're right.
Okay. So, I think I'm ready.
Okay, I'm gonna reshare my post.
Yeah.
For those of you interested in joining the conversation,
You can use that to join the conversation, and somebody should moderate and ah. Okay. I'm ready.
yeah.
All pumped up. You're going to cut all of this out, right?
Yeah.
I hope nobody's watching right now. So 4 more minutes. Did you put it on LinkedIn and everywhere else?
Yep. It's weird because I'm on YouTube, so I see you talking, but my computer's muted, and you're not talking to me on the phone, so it looks so weird.
Yeah, it is very weird.
Can people hear what I'm saying?
Well, it is most likely they can, yeah. Is there anything you want to tell the whole world?
I'm okay. Maybe you can call me after.
Sure.
Honestly, for these, I feel like you don't even need a moderator.
Yeah, it's better to have somebody that get the questions and so on, and they forward it to me, because I'm so paying attention to the talk itself. I don't notice if somebody asks a question and so on, and I want it to be a conversation.
Oh, I see.
And this could be as well a video podcast, just put it on our usual place, and we can go from there. Let's see if anybody else is joining us.
I texted Neil, but I think he might be doing something.
Maybe you want to let then Misha join and moderate? I'm not sure. Can you moderate?
Yeah, I can moderate.
Okay. You just should see everywhere in Zoom and in YouTube. See if somebody asking a question that you just stop me, ask me the question, and then I answer and we move on.
Sure.
Yeah. So if Neil is not here, now he asked for this. And if he's not here, then he's missing it.
I know.
Okay. It is about 4 o'clock. So is anybody on YouTube? Anybody there?
My computer's being really slow. I'm still trying to open up Zoom.
Okay.
No, nobody's here on YouTube.
Okay. Well, I'm going to start at 4 o'clock. One way or another.
Well, 2 people are watching.
On YouTube?
Yeah, but there's no comments.
Okay.
Okay, so then, I don't know, is it too late to go and change your settings on Zoom so that you don't have to go let people in and people can just join?
Or I can just make you host, then you can let them in, huh?
Sure.
Okay, let's make you host. Here you are. Yeah. Amanda.
Yeah.
Make host. No. Your host. And you can start recording right now. It's 4 o'clock.
Okay.
Recording in progress.
And Mitch says, hi, Dr. Abbasi.
Okay, so one of those people is Mitch. Okay, I'm going to stop our call. Okay, let's see here. So, I'm gonna make it a little bigger, that thing. Okay, here it is. So let's see who else is going to join us. So, welcome to Essence of Medicine podcast. This video podcast is in lieu of a case conference. And if you have time as well, I will show you some cases related to this podcast. And we are going to talk about sacroiliac joint. Amanda, you like Cinderella? You like princesses and so on?
Oh yeah.
Oh yeah. Now, sacroiliac joints is the princess, is the Cinderella of all our joints. Well, why do you think I say that? That sacroiliac joint is a princess Cinderella kind of joint of all our joint.
Well, my best guess would be based on just things I've learned from you in the last few months, which would be that it's not really a joint. I don't
Well,
know, that's my best
first of all,
guess.
what is Cinderella? She was orphaned, she was neglected, but she was practically a miracle. She was a, she was glorious. Orphaned, neglected, but glorious. And that is what sacroiliac joint is. We have two names for sacroiliac joint. One name is the chameleon joint because it can pretend to be causing problems that can come from other places. The other one is miracle joint. And you just edited that video of the patient who thought I'm a wizard, I'm a magician, because I did a 20-minute procedure and his 10 years pain that he literally told us that he didn't know if he can keep on going. If you remember, you edited that video that he
Yeah.
was seriously was in so miserable pain that he was seriously thinking about it, really exit.
Yeah, he was really suffering a lot.
Yeah, and but then we did a 15-minute, 20-minute procedure. Within a month, his life changed, and he was off narcotic, and he was, and we have that testimonial. So, I think Cinderella joint is a good uh, uh, description for this, and I'm going to tell about the joint. You know, a joint is something that moves two bones against each other, and sacroiliac joint. I will come back to that. Those two bones really don't move regarding each other, sacrum and iliac crest. And we used to start working on sacroiliac joint in early years of 20th century, and it was that's we didn't have any choice or chance or opportunity to work on the spine. Spine was too complex, but we start working for 30, 40, 50 years in the first half of the 20th century on sacroiliac joint until we had a way of dealing with the spine. And that way of dealing with the spine sort of put the sacroiliac joint in the background, on the back burner. And for 70 years almost, we neglected the sacroiliac joint. Once we start doing spinal fusion and in 1950s, we quit doing sacroiliac joint, and for a good reason. This is one of those things that the medicine was worse than the disease, that the cure was worse than the disease. The approach to the sacroiliac joint was so traumatic, so invasive, that we quit literally caring for sacroiliac joint. And in that time, and lots of our studies from that time, they knew that sacroiliac joint is a source of disease. As a matter of fact, most of the back pain then was attributed to sacroiliac joint, and we barely treated spine. But once we started treating the spine, that knowledge that we had about the sacroiliac joint as a source of back pain practically did go away. This is the anatomy of the sacroiliac joint, and as you see, it is where practically our torso hanging on our pelvis, or literally, I think this is one of those areas that the nature wasn't thinking straight. it's made for us to be on all our fours, but now we stand up and our 2/3 of our weight, our torso, upper extremity, head, is literally hanging on ligaments in our pelvis. And it makes sense that with advanced age, those ligaments can get loose, and significant number of our patient that lose ligament that cause hypermobility in our sacroiliac joint. They stretch the ligament, and the ligaments are very pain sensitive. Yeah, they have pain receptors and sensors, and they are pain sensitive. Now, this is a very complex joint. It's not exactly hanging, but there is some areas of the joint that trying to hold it. Is a very complex joint. This is information that we had for a very long time, but now it has been elaborated that if 100 people come to, let's say, chiropractor, family doctor with back pain, and they had no spine problem before, 22% of that is sacroiliac joint, not spine. Guess what? If that patient had a previous spinal fusion, that rate jumps up to 43%, meaning that, especially in our spine practice, we see a lots of patients that after spinal fusion come to us and they tell us that pain is not better, that they still have pain. And we start doing a lots of things, we maybe do even more surgeries, and if you are not trained, we are going to miss that 43% of that is actually sacroiliac joint. We call them, after we have done everything, failed back syndrome. Many of those failed back syndrome, they are not failed back syndrome, they are undiagnosed sacroiliac joint problem. And this is a misdiagnosis in many cases because sacroiliac joint can pretend to be lumbar spine, it can pretend to be piriformis, it can pretend to be pelvis problem, it can pretend many other disease. That is why we call it chameleon joint. And in many cases, providers, doctors, surgeons who are not trained to deal with the sacroiliac joint, they miss this problem. And here you see generally what the prevalence of the pain is when you have sacroiliac joint compared to other problems. Obviously, spine is still the highest rate of the pain, but in many cases, sacroiliac joint can be initial reason why people have pain. Amanda, that's something that you should be worried about that because younger women in the childbearing age actually have higher rate of having sacroiliac problem for one reason that the only function that we know of sacroiliac joint has is during the birth process, actually some enzyme come and loosen those ligaments so pelvis can open like an open book about 3 to 6 degrees, and that opens up actually pelvis aperture for the baby to pass through significant. For that reason, after a birthing process, delivery, for a few years, up to 2 years, the rate of sacroiliac joint is 7 times higher in a woman than in other times. Especially women, athletic women, when they put runners, that put a lot of peak pressure with those when they run, and after the birth, these are initial risk factors to have sacroiliac disease. As you see, everything I'm saying here, there are some additional references down below. Now, in these cases, practically sacroiliac joint is a pain generator, is where the pain started. And there are some local anatomical consideration that when we do the test, that literally this patient put the finger on their joint. Many times, we don't even ask the patient, show me where the pain is, and we just let them describe it. But if you let them stand up and put their finger, I ask them always to put their thumb where the pain is. If twice they put that within an inch from where the sacroiliac joint is in the vicinity, that we call that a 14 test. And obviously we have to rule out other nerve compression and other source of pain. So we have to get films, but the films are not diagnostic. They are just to find out if there's any other problem. After that, we do put pressure. I come back to that. We provoke this joint to see if by provoking the joint, the pain gets worse. Now, it's hard to provoke the sacroiliac joint without provoking some other areas, but there are ways to do that. And I will come back to that. But at the end of the day, to be absolutely sure that this is where the pain is coming from, we put a needle in and numb it up. Amanda, have you been in with the dentist? Did you ever
Yeah.
get a numbing of your gum?
Yeah.
How long does that last with you when you get that?
I think it lasts a few hours.
And that is because your mucosa in your mouth is very well perfused. Lots of blood comes in and out, and we wash the medication out. Sacroiliac joint is not well perfused, meaning that the medication, if you numb it up, it can last there up to few days. So, but imagine you go to dentist, he numbs up the right side and start drilling on the left side. What would you do if the dentist numbs up right and start drilling left?
I would probably cry.
Yeah, that's exactly what it is. If that is not where the pain is coming from, and you put pressure on it, you go do your daily activity. If you numb up sacroiliac joint, pain doesn't go away. That's probably not where the pain is originated. And if you numb it up and for a while numb, meaning maximum a day, 2 or 3, pain goes away, that is probably where pain is originated. So, and that is how we figure out if that's where the pain is originated. Now, again, because it's not well perfused, that effect can last much longer than when you just numb up for dental work. Now, for a long time, we used to approach the sacroiliac joint from the midpoint and go from inside out, from the middle to the outside. That was not a good approach. We made a lots of damage when we were doing that. For that reason, the results were so bad, so we practically stopped doing that. The only time we would do sacroiliac treatment was after a trauma, pelvic fracture, and so on. And we lost our ability to diagnose this joint well. And everything that we cannot treat, we cannot diagnose well. And that has been for the second half of the 20th century the case. We quit treating it and we forgot how to diagnose it well. Let's talk about the anatomy. The joint is extremely well protected with lots of ligaments because it has to be well protected, and our whole, almost 2/3 of our weight is hanging there. If it moves too much, this is one of those joint, we call it a joint, we shouldn't even call it a joint, we should call it a synostosis. If it moves too much, it is a bad sign. If it moves more than 6 degrees, it is actually it's something wrong with that joint. And there are lots of nerves going around it. One of the things that really set us off is many of these patients, they come to us, they have leg pain, and we cannot say why should anybody with a sacroiliac joint have leg pain. But if you look at this picture, that explains. You see on top actually the L4 nerve root and the L5 nerve root and S1 nerve root just passing next to the joint. If the joint is inflamed, there's lots of inflammation going around that, and then those nerves that are in the vicinity as well will be impacted, and then you will get the symptoms of those nerves. So sacroiliac joint can clearly give you symptoms of those nerves, which we could call radiculopathy. And we spine surgeons, we are used to somebody come with a radiculopathy, we look at their spine. This patient come with a radiculopathy, we look at their spine and we tell them nothing wrong with you, go away. And many of those patients go for tens of years and neglected and in miserable pain, and they're branded as pain seeker. We call them that they're faking, they're looking just for drugs or have secondary gain, whereas in truth we are just barking on the wrong tree, and we don't find out that the actual problem is not the spine but the sacroiliac joint. This joint is very complex. Every joint has a very smooth surface because two bones move against each other. Because this bone doesn't move, nature allows a lots of variability in this joint. So even in one person, two sides can look different. And this is for that reason, this is a hard joint to deal with because it look different in every single person. But generally it has two parts. One part that is we call boomerang or the articular part of the joint, and one part which called the ligamental. It's lots of heavy ligament connecting them together. And in reality, that is how it looked like. For people who have looked at our joint, they know, even though we call this white piece articular, this is a very dirty. If you would see something like that in any other joint, that would be an 80-year-old person. That joint has no function, would be really, really arthritis and arthrosis, bad joint. But for the sacroiliac joint, this is how it look like normally. In a regular person, do you see the very shiny part of this joint, Amanda, right there?
Yeah.
Most of the other joints are very, very smooth. As a matter of fact, I had a head of a hip joint in my hand. It was the smoothest thing I have ever seen in my life. And all of that looks shiny, absolutely smooth, but look at how this looks like. And for that reason, it is sometimes hard to get inside of the joint because it's not a real joint. It doesn't really have sometimes even a real good space. Here again, you see those ligaments that our body hang on in the sacroiliac joint. And on the x-ray, it looked like this. Now, I'm not sure if Neil is with us or not, but if he's with
Neil
us...
actually is going to be joining in a few minutes.
Okay. If somebody is here and like to join and explain this x-rays for us, because a series of x-rays coming up now. Now, let's look at the anatomy. Obviously, this is the sacrum, which is made of 5 bones. Those 5 bones, they come together, they make the sacrum. We called it S1 to S5. And sometimes they have a rudimentary disc between them, and sometimes don't. But we call, on the side of this the sacrum, there is a part of the sacrum that goes out. We call that ala. It comes from Latin for wings, because it truly looks like a wing. And I have a model of the bone here, and you see that part here. Doesn't it look like a butterfly wing, Amanda?
Yeah.
Yeah, that
can
is
see
called
that.
ala. That is called the
Yeah.
wing. And ala is the part of the sacroiliac joint right here, and right here you see on the x-ray. And obviously this is the end plate of the L5S1 on the S1 side. And this area here, we call that greatest sciatic notch. And that would be on a real person practically this area right here. And that is practically where some of the muscles, some of the vessels are coming out. And that is from the side, from the back, look like this is our sciatic notch. On the side, it looked like a hole. And that hole is right here. Obviously, you have 2 of that, and they overlap. And that's why you see 2 kind of round thing here.
So when you have sciatica, is that related to your SI joint when you have sciatic pain?
That's a good question, Amanda. See, these nerves, they come together. When they come together, they make one nerve that's called sciatic nerve, which is in the back of our actually spine, in the pelvis. And anytime any of these nerve roots are compressed, they cause us pain. We feel the pain going back of the leg down, and that is what sciatica. Now, sciatica is when any of these nerves are pushed in the spine, but sometimes as well, the irritation of the sacroiliac joint can irritate some of those part of those nerves. So sacroiliac joint can clearly give us the so-called sciatica symptoms. For a long time, we didn't know why, but now we know. So
And then, so how do you distinguish between SI joint stuff and sciatic pain.
Yeah, well, that's exactly the point. That is difficult. That is difficult to distinguish between them. And the way we distinguish at the end is a series of specialized tests, and then as well numb up the sacroiliac joint, see if the pain goes away. If
Okay.
the spine is the problem, numbing up sacroiliac joint doesn't make the pain go away. But if the sacroiliac joint is the source of the pain, numbing it up, it does. We will come back to that in few minutes. Now here we see the view of the pelvis. This view is practically looking into the pelvis. We call that inlet view. As you see, it's almost like an inlet. Oh, here is Neil. Hey, Neil.
Hey guys, how you doing?
Good. Well, by your request, we are talking about the sacroiliac joint.
Amazing. Yeah, I had some requests from a few medical students that they wanted to see this.
Yeah,
So
we will
thank
put
you
it
for
online. Now, Neil, I was just explaining to Amanda that I want to start coin a word phrase for sacroiliac joint. I want to call it Cinderella joint.
Where'd you get Cinderella from?
Amanda, what is specific about the Cinderella that it has? What do Cinderella and sacroiliac joint have in common?
Well, Cinderella was abused by her step family,
Neglected.
neglected.
Yeah, it was orphaned, neglected, but she was glorious.
That's actually really good because I had my meeting with Eaton or Eaton, he tells me to pronounce it. And he was telling me about how the SI joint can be easily like misdiagnosed and you think it's like radiculopathy or things like that.
And we neglected that for 70 years actually because our solution was worse than the disease. For 70 years we did neglect the sacroiliac joint. And because we couldn't treat it, we practically forgot how to diagnose it. So it was neglected. But the reason still is Cinderella is and glorious because we have a two words additional phrase for sacroiliac joint. We call it chameleon joint because it literally can pretend to be a problem of the hip, pelvis, piriformis muscle, or even lumbar spine. But additionally, it can as well have similar symptoms, give the patient similar symptoms. We have another word for that. We call it miracle joint, and we just put a testimonial of a patient out there. He literally called me a magician or a wizard because for 10 years he had so much pain he was ready to commit suicide because everybody told him he's crazy. And then I do a 20-minute procedure. Within a month, he's off narcotic, his pain goes away, he can do activities. He thinks I'm a magician, whereas I just fixed a problem that nobody looked at to
Yeah.
find out about
Chronic
that.
pain is difficult. You know, you'll go so long in your life, people not believing you, being misdiagnosed until you find the right person to find the right answer.
Well, and nobody can find the right answer if they are not looking in the right place. And we have not looked in this place for a long time. So now we are talking about the anatomy of the pelvis and sacroiliac joint and X-rays. And obviously we talked about the sacrum, talked about the ala, greater sciatic notch, head of the pelvis. Neil, do you know what we call the upper posterior part of the sacrum?
Upper posterior part of
Here,
the sacrum.
this part of the sacrum, right here where my marker is. Ethan, do you know what we call that area?
I'm not sure.
We call that promontorium. Let's come back to that.
Promontorium.
It's important.
Does it stick out or something?
It is.
Yeah.
It does stick out. Here, this is my thing. This part, here, here,
Yeah.
we call that promontorium. Do you see how it's sticking out?
Yes.
It promotes itself out. Do you see that? Okay.
I see that. Yeah, in that spine you have there, I see it, but I think it's different for me to see it here in the image.
Yes, it's not the anatomically correct. Now here again, here is the promontorium. This is the disc, and you see the disc here. This is the inlet view. this is the lateral view. In the inlet view, practically you're looking at the sacrum, axial view of the sacrum. Practically, if this is the sacrum, the inlet view looked at the sacrum as it comes at you.
Okay.
Practically, inlet view is the axial view of the sacrum. That's the only time in a spine you can have an axial view with a regular x-ray.
Okay.
And guess what? Then we have the accordingly outlet view. Outlet view is true, this would be AP view to the patient, but if you go this way, you get a true AP view of the sacrum. A true AP view of the sacrum is so-called outlet view. And in the outlet view, obviously, you're looking at the sacrum face on. And so you see the foramen much better. You see the coccyx much better. And obviously, you see the sacroiliac joint as well here. Now, to see the sacroiliac joint very well, you as well need to not only go a little this way and look at it, but as well sacroiliac joint is at an angle. Then you as well need to move your camera a little to the side so you can look at the sacroiliac joint, which is a little angled. Okay? So there are many views, many special views for sacroiliac joint. And I think if you get out of this talk today only how to understand and interpret the sacroiliac joint, you're ahead of most of your peers, except the radiologists.
Oh, that's fair.
Understand the anatomy and the radiology, the finding of the sacroiliac joint.
Okay.
Now, let's look at the again lateral view. We talked about the Neil. I'm going to ask you, and then maybe Dr. Coach, what is sciatica? Describe to me what sciatica is. Amanda explained that, but I want you to describe what sciatica is.
Oh, sciatica. Okay, I better not embarrass myself in front of
you won't.
Dr. Coach here. So sciatica and like radiculopathy, there's all different terms. So sciatica is the shooting pain that's going to happen down in the posterior thigh. And specifically sciatica, it's coming off of the plexus, which is coming off of the lower spine. And this pain can be either happening from compression on one of the vertebral bodies, and then that can cause the shooting pain down the sciatic nerve, which is going to be a collection of the plexus coming down. Am I off? Am I close?
No, you're right on. You're right on.
Okay.
Okay?
Yeah.
Now, the practically, sciatica is that shooting pain back of the leg. And when we start dissecting the spine, we saw a very thick nerve in the back of the thigh. We called it sciatic nerve. Okay? And that sciatic nerve actually is a accumulation of some of the nerves in the lumbosacral plexus, right? Dr. Coach, do you know what nerves they are that they make the sciatic nerve?
L4, L5, S1, S2, S3.
Yeah, it's in front of you right here. Look at
it's
that.
in front. Oh, look at that. It's right there.
L4,
I didn't see that. But it's right there,
L5, S1, S2, S3. Okay? They come together, they make the sciatic nerve. Now, obviously, as you see here, especially L4, 5, and S1, they have to pass over the sacroiliac joint to come together, meaning that irritation of that joint can cause irritation of the nerve. So for a long time we had no understanding why sacroiliac joint would give us sciatica, but now we know. So it is sacroiliac joint not only does not rule out for a long time we spine surgeons, we thought any kind of radiculopathy rules out sacroiliac joint problem. Now we know not only it's not the case, but just the opposite.
So how can you figure out that the SI joint is irritating the sciatic nerve? I feel like that'd be very difficult to diagnose.
Amanda, how would we do that?
By seeing if the pain is coming from the SI joint with numbing.
Here you are. You see, Amanda is an expert now in the sacroiliac joint. We numb the sacroiliac joint. If it's coming from sacroiliac joint, then pain improves. We call it pain generator. If it's coming from somewhere else, it doesn't. Now, I ask Amanda, Neil, you go to the dentist, he numbs up the right side and start drilling on the left. What would you do?
I'd scream.
Yeah. So the same here. You go to somebody who knows how to do the injection. He numbs it up, but if your pain is coming from his spine, that does nothing for you.
That
But
makes
if the
sense.
pain is coming from the sacroiliac joint for a day or two, that can actually improve the situation. I asked
So
Amanda.
it'll be trial and error.
Well,
Yeah,
we wouldn't call
in a
it
way.
trial and error. We call it, but there's a term for that. We call it diagnostic injections.
Okay.
Okay. Now, Dr. Coach, how long does the numbing medication that the dentist does last generally? I'm sure you have
An
been
hour,
with the
2
dentist.
hours, something like that.
Usually about
Not
4
very long.
hours.
4 hours. Okay.
And-
Okay.
But why does the injection in the sacroiliac joint can last even a day, 2 or 3, whereas in our gum, in our mouth, it lasts only 4 hours?
Well, it depends what you put in the injection, I guess. I mean, if you put in some steroid, it might last a little bit longer than if you just put in a numbing medication.
Well, the numbing medication itself lasts longer in the sacroiliac joint because in your
'Cause it's
mouth,
not well perfused.
yes,
The
you have a high
mucosa, yeah, that makes
perfusion in the
sense.
mouth.
Yeah.
It washes it out, whereas this joint is not very well perfused. And if you do it right, you put it actually inside of the joint, and that has a totally different half-life than what you just put in the tissue where it's perfused. So it can last up to three days. But I wouldn't be surprised if it just lasts only few hours, meaning that if while numb pain goes away, we know that's where the pain is coming from. So let's move on because we have a lot of ground to cover. Now, look at that. Do you see all those major vessels?
Yes.
Well, based on that, Neil, if you had to approach the sacroiliac joint, would you like to approach it from the front or back?
No, posterior approach.
Posterior, right? Now, in the back, I'm going to go back now here. Look at you. Do you see all those ligaments?
Mhm.
If you have to approach the sacroiliac joint from the back now, obviously they are not going to bleed, but do you see all those heavy ligament?
Yeah.
You have to destroy them to get into the joint.
Oh, you can't
How
maneuver
else?
around.
How else are you going to pass them without cutting into them?
Yeah, that's true.
And that is
I mean,
why.
I see that there's some like holes or foramen that.
Do you
could
want to use the
reach in there?
foramen? You want to use the foramen to get there?
I guess foramen is not the proper term, but I see
No, that
some
is a
in there.
foramen. That's a proper term.
That
Those
is?
are
Okay.
what you see there are these foramens right there.
There
In the
we
back and front. Here. Let's go back. Here, in the back and front. These are the foramen where the nerves are coming out. You want to use those foramens? No, you don't.
go. No.
No, because nerves are coming through those foramens. You want to stay away
Okay.
from those foramens.
Yeah,
So-
that'd be inappropriate. Yeah.
So, practically, what I'm trying to tell you, even though you don't want to go from the front, you don't want to go from the back, from inside out. You do not want to go from here to here, and you want to go from outside toward the. But then outside there is this iliac crest. Now, the magic of last 10-15 years has been that we figured it out the best way to get to the sacroiliac joint without have to go through these vessels, without have to go through all the ligaments, and go through and access the sacroiliac joint through the iliac crest. That has been the magic of that. Yesterday, let me go back. I used to do sacroiliac joint fusion 10 years ago, and that was a massive surgery, like 4 or 5 hour surgery. And obviously in that case we would approach both sides and so on. But now when I do it, and that was 4 or 5 hour surgery with 1,500 cc of blood loss. Yesterday I did a two sacroiliac joint fusion. No, 2 days ago. And today morning we did one. Each of them were half an hour procedure and 20 cc of blood loss. And all those patients went home within 2 hours after the surgery.
That's amazing.
That is truly a magic.
Yeah.
That you remember we called it miracle joint.
The miracle
That
joint.
is a miracle joint.
That's better for the patient. It's better for you in the OR as well. So
That is better for everybody because we don't have to traverse all these vessels, we don't have to traverse all those ligaments, and we don't destabilize the spine and the sacroiliac joint. The only thing we have to pay attention, we will come back to that, is that artery, superior gluteal artery. Okay? When we do the approaches that I'm going to describe. So, we talked about that. It is mostly the disease of the younger woman, athletic woman, especially if they have after the birth or delivery, the rate of sacroiliac joint is significantly higher. So if a young athletic woman has given birth in the last few years, come to you, your antenna should go up. Okay?
Okay.
Now, lower back pain, we talked about that before. It's a common problem. And we talked about that as a matter of fact, I want to show you this slide one more time because you have to engrave it in your brain.
Okay.
Almost 1/4 of the patient who come to you with a lower back pain, the problem is the sacroiliac joint. And if they had a previous fusion, almost half of them will be sacroiliac joint. Almost. Okay? Engrave that into
that's
your
very
brain.
significant.
That is significant. Especially these are younger people that have their whole life in front of them. So let's go on we talked about the prevalence of this sacroiliac joint problem. This is quite significant, almost 1/4 to 1/5 of them. Now I'm just going to bypass few of this slide, and we talked about that many things can be many symptoms that come from sacroiliac joint can confuse you. You think it's a spine or something else. We should get always films, look at the spine, but the films we get, we want to make sure that it's not the spine, it's not the pelvic tumor, it's not something else. But the films themselves are never diagnostic for sacroiliac joint because sacroiliac joint doesn't have a regular way to present itself. It's not has a unique, most of our other joints have a unique appearance. Sacroiliac joint doesn't. I was telling Amanda that this is how sacroiliac joint look like. If this was any other joint, you would say this is an arthrosis, bad joint, need treatment. But this is a normal sacroiliac joint because it doesn't have a function. Nature tries everything, and it has variation. Even in one person, right and left sacroiliac joint can look different. Okay, so let's move on. And I think we talked about that radiculopathy is compatible with sacroiliac joint disease. That is one of the take home, okay? Diagnostic. We talked about many of the symptoms, especially these are patients that when they turn from side to side, twisting of the pelvis can provoke the pain. For some reason, and I'm going to explain that why, this patient, they come and tell you, especially in the night, the pain is much worse. Why do you think that's the case, Neil?
So I'm assuming it's because of just the use of like going through your whole entire day and the stress that it puts on your lower back.
Warm, but not hot.
The thing is that at night, the body will automatically turn itself every like 20 minutes or something, just because you can't put too much pressure without getting a pressure ulcer. So you automatically adjust every 15, 20 minutes, right, Dr. Abbasi? Somewhere around there. So it's a lot of movement. And the problem is that movement is what really is causing the pain with these people normally. Because if the joint's stable, it doesn't move, then there's not really any pain. And so every time they move, they get the pain. And
every time they move, they wake up. You do it every night. You put a camera out, Neil, for tonight and watch yourself all night long. Every 20 minutes, you are turning, changing the position. This patient, every time they move, they turn, it wakes them up. Pain wakes them up.
Okay.
Typical thing. Going stairs up, causing problem. And if they had sometimes they tell you they had a history of minor trauma. And CT and MRI is a standard of diagnostic only to rule out that there is not another problem, but is never diagnostic. Especially CT sometimes can cause you osteophyte, vacuum effect, and the irregular the surface of the joint and hyperostosis, but all of that is suggestive, not diagnostic. The reason for that
Right.
is lots of people without sacroiliac joint have similar findings.
Right, Dr. Coach was telling me in our meeting earlier this week that you have to treat the patient, not the image. So even though the image can help you, like especially with the SI joint here, since it's so easily missed, you
Yeah.
have to do that. So that's why the diagnostic injection, that makes sense.
Yeah,
Yeah.
but we will come back to that. Now, this is the pattern of the sacroiliac joint pain and pain in the leg. You see that there? This could be almost anywhere in your legs. But if
Wow,
you look
yeah.
carefully, it's mostly L5, L4, L5, S1, maybe some L3. But practically, that makes sense that people are confused. They'll see radiculopathy. They go for that foramen to see that you have L4 radiculopathy. So is it lateral recess in L3-4? Is it foraminal stenosis in L4-5? Nothing there. Now get out of my office. It's nothing wrong with you. You just want pain medication, whereas the patient in truth has sacroiliac joint. These patients are miserable. They wait. They stand up after a month. They come to my office. They hug me because nobody took them serious. Nobody. They doubt their own sanity. Okay.
Yeah.
Okay. Now I'm not going to go this because we have a lot to cover. But this is
Yeah.
more or less the typical pattern. Do you see? What would you call that pattern? It's mostly L4 and some L5.
Mm-hmm.
Now, let's make
The
an-
dermatome?
look
Is
like
it
that.
on
It
the
look like
dermatome
that. It
pattern?
look like L4 and L5 dermatome,
Yeah.
but it makes sense if you know the anatomy. Anatomy is everything. Look at that. Look at that L4.
Yep.
Right on top of it, in the middle of the joint. Now, look at that distribution. It's like magic. When you know the anatomy, it's like magic. Things make sense.
Mm-hmm.
Now, I'm not going to read this for you, but we will put it online. You guys can go and look back.
Definitely, yeah.
But these are some of the history risk factors for the sacroiliac joint. And again, the people cannot just describe it well. It just can be anything or everything.
It can be vague sometimes.
Can be very
yeah.
vague, especially when they climb up the stair and so on and so forth.
Are there certain physical exams you do to try to elicit the pain in that area?
Yes, we do.
Mm.
General,
Which ones?
Well, we call them provocation tests, okay? There's some other thing that you have to rule out, that they don't have infection or a tumor. You have to get a pelvis CT. You have to get there's a protocol actually for that. But then, this is the 14 test. You ask them, we do it very rarely. That truly we say to the patient, put your finger there, where is it? Okay? If they put it within an inch of the same place on the sacroiliac joint twice, that's a positive 14 test. And then we have to use patient's extremities to provoke that joint. You see the Faber test, you see then the so-called distracting test, what it does. You see the compression test, you see the thigh thrust pain test and so on, and Genslin test, where you practically use the pelvis and the legs to as a fulcrum to put more stress on the pelvis. Now, did you see all those ligaments that we saw last time in the other
Yes.
picture? It is a very stable. It has to hold your weight. It's hard to provoke it. For that reason, you have to do almost, use your femur as a fulcrum to provoke that. And that takes time. And that is actually one of the misery of diagnosing the sacroiliac joint. Surgeons are so busy, they don't want to take the time to put the patient on the thing and do all these tests. That is why we have come up with so-called sacroiliac combined rapid test that you and Dr. Coach are going to evaluate, because if we can provide them with a tool for the surgeon, for a tool that they rapidly do that and they don't have to spend half an hour to go through that, it's more likely they can diagnose it. One of the problem of the diagnosing the sacroiliac joint is this provocation test. You have to put the patient on the table. You have to go on top of them to really do that. Surgeons don't have that time. For that reason, lots of people are in misery because we surgeons are too busy to go through that. Now, we have been able to provide this rapid combined test that then opens up the core. If that's positive, you send the patient to physical therapy. They can take the time within their thing and do all those tests for you. And then if you have 3 of those tests positive, literally you have 66% sensitivity that it is the sacroiliac joint.
Okay.
And then we go to the next step, the diagnostic injections. Because this joint is very variable in every person, even right and left is different, this is one of the hardest joint to inject. Now the good news is, because most of the nerves and so on are not in your way, it is a low complication for the injection, but is the highest complexity technically to do it. So first of all, we have to use the boomerang, the articular part of the joint. We have to use a low volume, 2 to 4 cc max. Most of them I give about 2.5 cc on each joint. You have to be sure you are in place, meaning you are going to use either X-rays or a CT. And then you have to put contrast to make sure that you are in the right place. So there's a protocol to that. Not every injection can be used for diagnostic reason. Sometimes as well you can put actually injection along the what we call the ligamental part of it for therapeutic reason. But for diagnostic, you have to use the articular part or the part of the joint that has cartilage and be as close as you can to the articular and intra-articular part of the joint. Now, we talked about the low volume and the fluoroscopic image. As a matter of fact, if not all the pain has to go away. If 75% of the pain repeatedly goes away, the diagnosis is confirmed. And it used to be 3 injections, but the result of the treatment has been so good, most of the insurance company now accept 2 injections because they don't want to pay for a 3rd injection than for the treatment. They know that, and this is really has been one of the miracle of the sacroiliac joint, of the musculoskeletal, that we can now effectively treat that. And the treatment of that, I'm not going to go through all this protocol, but this is the diagnostic protocol for that. Again, this will be online. You can go back, take a snapshot, a screenshot of it.
What imaging do you use to guide your injection?
I use X-rays. In the
X-ray?
cases that I'm not sure, that for some reason that we don't have the proper result, but I know this is a sacroiliac joint, then maybe I was in the wrong place. Then I use a CAT scan.
Okay.
Now, if it's more than 75 is positive. If it's 50 to 75% is equivocal, meaning I have to look for combined other reason as well. If it's less than 50, usually we don't consider it diagnostic.
Okay.
Treatment. It is a very hard joint to treat. There is not a really good bracing mechanism for that. Obviously, physical therapy, making the pelvic muscle, gluteal muscle stronger is always a good idea. Sometimes we even, obviously, we put, when I do my injection, at the same time I put as well steroid. And yesterday, actually I saw a patient that I did 3 injections in 2015. I didn't see the patient for 7 years now, and after 7 years, patient is coming back.
So that's good.
That is good. 7 years.
Yeah.
7 years.
They weren't bothered to come back. That's how you know you did well.
Well, and so the injection, that the way I do it as well, I put steroid, and you have a biphasic improvement if it's truly sacroiliac joint. Biphasic means, Dr. Coach, do you want to describe what that means for the sacroiliac joint injection?
I'm not sure exactly what you're referring to. The fact that you have to do it several times.
No. See, if you put steroid and local anesthetic in the injection, you want to describe it now?
Yeah. So what you do is you put the so what happens is that the numbing agent will work for several hours,
Or a day or two.
or a day or two, given the avascularity of the SI joint. But it takes about 2 or so days before the steroid will start to take effect, because the steroid actually has to go into the cell, into the nucleus. And then it has to, make the DNA, produce new proteins, whatever. All that takes time. So steroid usually takes about 2 to 3 days to start taking effect, and then it can last for, several weeks anyway, or months.
Actually, even a little longer, most likely. So you get initial improvement, pain goes away. Like they say, "Oh my God, I'm a new man, a new woman," and then they overdo it. 2-3 days later, when the medication is gone, pain come back with a vengeance.
I'm sure that's terrible.
Yeah.
Because they get that brief relief,
Yeah.
and then it goes back to normal until
And
the
then
gene expression
4
takes
to
off.
7 days later, the
Yeah.
steroids start working, pain get better again. So get better, get worse, get better. And that steroid part lasts longer, obviously.
Yeah.
Okay?
That's back to the basic sciences. Steroids are intracellular. They go to the intracellular receptors.
I think we talked
Yeah.
about it not long ago.
Yeah, it goes into the DNA. Yeah.
Okay, now, if we do all the things that we are going to do and they don't get better, for a long time we didn't have option, now we do.
Okay.
This is what we used to do. And this is a horrible surgery because look at that. To do this, you have to destabilize all those ligaments to just get in. Now, for the last 10-15 years, starting with the SI bone, they have these triangular plugs that you put across from outside to inside. You go through the pelvic, truly lateral to medial. You put these plugs and you make it stop moving. Surprisingly, this works pretty well, actually. And what I don't like about that the company who made that, based on one study, they went and promoted that as the only way it works.
Oh. When you hear the only way, that's when you should have some red flags come
That's
up.
right.
Yeah, well, the idea is that you stabilize the sacroiliac joint, and it's a very far stretch, meaning you don't know nothing about anything to think the only way it works if you put this device. As a matter of fact, many surgeons before, they used to put what we call trauma screws in the pelvis, and that worked well. And these are different kind of screws. They go from outside to inside. As a matter of fact, we know a screw and a nail both can connect two things together, but the screw is 4.5 times stronger than a nail. Now here you put 3 nails.
Okay.
If
Yeah.
you put 3 screws, the strength is even more.
Is that because of the teeth on the screw that's
Well,
able to?
why do you think that when do you ever do woodwork?
Yeah, I have. Yeah, especially with my
Nail
dad.
screws.
So
Why do you think a screw is stronger than a nail?
the screw, because it's creating its own groove with the teeth around it.
Yes.
So as it's cutting its way through, it makes its own little house, and then
Yes, it
won't
makes
come
a.
out.
Yeah, exactly. Now, this company who promoted this, and I think to detriment of the patient's care for a very long time, that this is the only way it works. Now they came out with a screw themselves. Okay, for many years, people who decided to use any other screw or device, they had problem to get it approved by the insurance companies because insurance companies, based on the promotion of this company, said these are the only thing we pay for.
Ooh.
And I think that is truly a bridge too far to say it works because you use this device and nothing else. Now, these are other companies that have screws and they work as well, if not better. And now let's talk about. But these are practically 2 different approaches that going from medial to lateral here,
Okay.
medial to lateral, which is the SI bone. And then there is another approach that you go perpendicular to the sacroiliac joint itself. So going this way or going this way, perpendicular to the bone. And that is my favorite approach, because imagine if you put the two screw, two piece of wood together, you can go this way,
Mhm.
or you can go this way. Probably
Okay.
both of them work, but going perpendicular to the bone or to the sacroiliac joint is my favorite. Now it just happened to be the sacroiliac joint is not like that. It is like that.
It's
For
on an
that
angle.
reason, you have to put the screw at the non-perpendicular to the patient angle to get to be perpendicular to the sacroiliac joint.
So similar to woodworking, do you use a drill bit to first make the hole and then put a screw in, or do you just straight put in a screw?
Very good question. I come to that in 2 minutes, but you're
Okay.
right.
Before we continue, I just want to point out we have 3 minutes.
Well, I'm going to continue that a little longer than 3 minutes, because I think that is a good conversation to have. And we started at the beginning of our thing for a long time. We didn't really start the thing. So I really want to continue that. But let's go.
We could do it in the course on YouTube as well.
Yeah. So first of all, what I do, I draw the shadow of the sacrum on the spine, on the buttock.
Okay.
And here you see, this is the shadow of the sacrum on the buttock.
Mm-hmm.
Then I identify the pelvis tilt, meaning that I go from promontorium to the middle of the sciatic notch. And these are what you see. This is the shadow of the sacrum. This is the from promontorium to middle of the sciatic notch. And the middle of the sciatic notch is actually your skin cut in the perpendicular to the bone. And then literally the entry to the iliac crest is just anterior to the shadow of the sacrum. You choose that because you still have to go through the iliac crest before you are centered on the sacrum. So entry to the skin, entry to the iliac crest, and then here, that is what you see your guide wire. Then it goes through the sacroiliac joint in the inlet view, and then in the outlet view you decide how far you want to go. And you go and you are just shy of the foramen, S1 foramen. And then practically put your screws in. The result of this surgery is tremendous. Okay? This is the control group that didn't get better, but the people with the treatment, they got better. And Dr. Pauly, who is in the University of Minnesota, is actually one of the pioneers of this, and has talks in every place, and lots of information out there. This is Minnesota-grown kind of study.
That's
Okay?
amazing.
Yeah. So this is the result. You put the screws in through the sacroiliac joint. Now to put those screws in, you ask, how do you do that? First you put the guide wire, then you put a dilator, dilate the muscle, then you put a small drill, then you put a big drill, then you tap it, and then you put the screw, and then you pack it on, and so on and so forth.
Okay.
The set is like a 40 to 60 piece set, comes in and out. Now,
It's more complex than woodworking.
it is way more complex than woodworking, except you do it with a trident. I did a lot of this. Based on that, imagine you create a screw that it's its own drill, it's its own tap, it takes the stuff in, that does everything you need to do in one set. And that is what the trident is. That
Okay.
what you see is all you need to do it with a trident. That's all
Wow.
what it is. You put the guide wire in, then you literally you put the main screw in, and the other screws go through the channel inside of the thing. From the skin to skin, when we do it with trident, is a 13 to 15 minute procedure. Skin to skin. From
That's
the,
amazing. That's
when-
fast.
That is this. It is not about being fast. You see, sometimes some of my colleagues, they think I'm self-promoting when I say I do that surgery in 15 minutes, because they need 4 times longer for this, and they think I'm saying I'm a faster surgeon, whereas I'm just using a different tool.
Yeah.
I don't
Be
like
more efficient. I mean, it's safer to use less OR time, less time on the patient to be under anesthesia, under the trauma from the cauterizing and everything. Less exposure for you to any sort of radiation or things of that nature as well.
Every additional half an hour under anesthesia adds 17% to the combined risk of the surgery. And here, I don't have to poke through patients and go next to the superior gluteal artery 3 times.
Yeah.
I just go once, and the second and the third screw, this is one of the screw in place, this is the third screw as you see here, they go
Yeah.
through the same channel, and then the end result is this.
Wow.
That's why we call it trident.
Okay.
So, and Dr. Aya today helped me with a different system where you have to go through. One of the things that she was telling me that trident is like 10 times easier than the system we use today. And it is, because you don't have to go through all those steps. Additionally, one of the problems with the regular fusion is that either you broach it or you put a drill in, and then you take your drill out to put the screw in, right? Then you have a 1 centimeter, half an inch, almost half an inch hole from the spongiosa of the sacrum and iliac crest to outside.
Okay.
What is it filled with, Dr. Coach? What is the spongiosa is filled with?
Tuberculosis, I guess. I mean,
It's filled with blood.
Oh, blood.
Now
okay.
you have a 1 centimeter hole from that cavity to outside. In 1/7 to 1/10 of the case, it start bleeding like crazy. But if your drill is your screw and it's all fills the hole, then you don't have that bleeding either.
Oh,
So,
makes sense.
and this is the result of the trident in the pictures. Now, the result is amazing. The result is that these people within a month regain their life and are able to function again. So, these are some of the cases. These are some of different screws. And you see, we published a paper as well about how to read the fusion. Some people say you don't even have to have a fusion. Just instrumenting it, making it stop moving is enough. But in the long run, if the bone doesn't grow, eventually the screw will get loose. So I am a total believer that you have to have a fusion for constant results. So I'm just going to go and show some cases here. And here you see different pictures, how these different screws look like in the lateral view, in the outlet view, and as well, I'm just going to stop here because I think we went over our time, but not by much. So Amanda is still happy with me, hopefully, that I'm just 3 minutes over our time. So, Neil, maybe we have, or anybody else, maybe we have time for 1 or 2 questions before we conclude our the essence of medicine sacroiliac joint video podcast.
I have a question, Dr. Abbasi.
Yes.
I've noticed, because I tend to go through the entire cluster for SI joint, and one thing I've noticed, an almost 100% correlation is when they're positive for the 3+ cluster test, they also have very weak glutes, like 3 out of 5 gluteus maximus. And in fact, I thought I found an exception today because I had a patient who didn't have any positive provocation test, but he still had weak glutes. But then I looked at his imaging, and it turns out that at Reyes, he had 2 sacroiliac joint diagnostic injections that were positive.
Yeah.
So even though I didn't find it on the physical exam, but it still kind of it shows that he had SI joint dysfunction and he had the weak glutes. Do you think that's that's nearly 100%?
Yeah.
You think that's what's the cause there? Do you think that the weak glutes is causing SI joint dysfunction or vice versa?
So let me ask you another question. If a muscle, first of all, there is no single muscle that works on the sacroiliac joint. If there is, you can put your name on it. There is no muscle that works on either side of the sacroiliac joint. I mean, going from sacrum to iliac crest.
Right.
All the muscle, they cross it. They go from femur to sacrum or to our spine, and all those muscles they go across. But gluteal muscle, they work across the sacroiliac joint. What do? They put more stress on the sacroiliac joint. What happens when the action of the muscle provoke the pain? You're automatically going to use that muscle less.
Got it.
And it's a combination of giveaway weakness plus that you're going to use that muscle less that
Makes
leads
sense.
to gluteal muscle being always
Atrophy.
affected with the sacroiliac joint. No different than if you have a shoulder problem, you're going to have deltoid weakness. Because if you put your deltoid to full strength, it's going to cause you more pain. So maybe time for one more question, and then we call it. We finish it up.
I have a question. Is SI joint related to anything in urology? Any sort of pain in that area?
In the
Or any sort of
urology,
dysfunction in that area?
can you repeat the question one more time?
So in relation to the field of urology,
Mm-hmm.
so and yeah, in the field of like organ dysfunction or like sexual organ dysfunction, does SI joint or sciatica or anything, I guess, from the L4, L5 to S3 region have to do with that?
Well, what we did not see in this series is the pelvis anatomy. Now, you can imagine that the pelvis anatomy is very, very complex, and there are lots of other structures there. Can you imagine that if there's inflammation going on, and that's what it is, you overstretch the ligaments, and there is lots of inflammation, and anything in that area can be inflamed. And you as well remember that we said that one of the names of the sacroiliac joint is what? Chameleon joint.
Yeah.
It can pretend to be a lots of things, and and many of these patients do present with truly untypical symptom, because pelvis is very, very busy area, and has a lot of anatomy going on there. As a matter of fact, I have some other picture that shows truly how complex the anatomy of that area is, and I wouldn't be surprised that within the next year or two, I see, even though I have been treating that for a very long time, I wouldn't be surprised if in next few years I will see few other things that I have never seen as a presentation for sacroiliac joint. Again, because this is a complex joint that can present in many, many, many different ways. Just to visualize that to you, I'm going to bring this here. This is the pelvis anatomy. Okay? Iliac arteries here and the veins, and then all those nerves going around. What you do not here, you see the sigmoid colon. What you do not see is the bladder. Okay? Now, here you see again how busy that anatomy is, right?
Yeah, no, it's extremely busy. I remember from my anatomy class that this was one of the hardest parts.
Yeah, here is a very busy anatomy. So imagine that if there's inflammation going on there, that makes sense again once you understand the anatomy. Why it's a chameleon? It's inflammation. Inflammation is a pathophysiological reaction. There are literally some factors are released in that. Those factors, they just irritate the hell out of lots of different structure that then can present with their own kind of symptom complex. Hence, chameleon joint. Okay? Okay. Any other question?
Let me see if there's any questions in the chat. Doesn't seem like there's any. Everyone says it's very challenging and stimulating. So
Excellent. Well, now it was really my pleasure. This is one of those areas that I go and promote out there, because lots of these patients, they truly have been neglected for a long time. They stand up after 4 weeks, they hug me because they have been told they cannot be helped. And I do just a 20-minute procedure. I change their lives. This has been extremely rewarding for me as a surgeon to be able to see how this patient improve. So
from this course, so we talked about radiculopathy. We also talked about the SI joint. I remember once Dr. Coach was talking about trigger points. So in what relation is trigger points to this as well?
Well, trigger point, in practice, trigger point injections is when you put a needle in one area that you think causing pain, and pain improves if that's where the pain is coming from.
Okay.
Now, sacrum is a trigger point for this kind of pain, but because it's a articular injection, we don't call it trigger point injection. We call it sacroiliac joint injection. Trigger point,
Okay.
we call it if that can be anywhere in your body. And we don't want to have 500 different names for that, like a deltoid injection or a scapular injection or paraspinal muscle injection. We call that generally as a trigger point injection. But if the point we are putting the medication is well defined, we call it by the definition of that location, which is practically in this case sacroiliac joint.
Okay.
Okay, well, at 5:12. Thank you,
Yeah.
thank you very much, and thank you, Amanda, for sticking with us and helping us to moderate this. Thank you, Dr. Coach and Neil, and
Thank you,
we
yeah.
talk soon. Okay. Okay.
Of course.
Thank you.
Thanks, guys.
Bye bye.
Thank you very much.
See you later.